Hi, my name is Lawrence Ong. I'm an internal medicine resident over at Delft Seton Medical Center, and I'm here to present to you a case. This case involves Hodgkin's lymphoma presenting with a paraneoplastic cerebellar degeneration syndrome. So this case begins with a 31-year-old African-American man with no known past medical history. He presents to the emergency department with a chief complaint of gait instability, confusion, slurred speech, and a non-focal headache. In the past 6 months, he has had unintentional weight loss, fatigue, joint pain, and night sweats concerning for malignancy. His physical exam was notable for supraclavicular lymphadenopathy. His neurologic exam was non-focal. He was able to answer some questions and follow commands, although at times somewhat confused. Vital signs were within normal limits, and lab values did not suggest any acute abnormalities. On imaging, including CT, chest, abdomen, and pelvis, he had extensive mediastinal, hilar, and parapancreatic lymphadenopathy concerning for a lymphoma. The MRI brain pictured here revealed enhancement of cerebral and cerebellar sulci, and then some enhancement of white matter within the cerebral hemispheres. Biopsy results, including supraclavicular lymph node biopsy, showed CD30 large B cells consistent with Hodgkin's lymphoma. Bone marrow biopsy did not reveal involvement of Hodgkin's. Lumbar puncture showed a pleocytosis with a lymphocyte predominance. CSF cytology and flow cytometry were negative for Hodgkin's, suggesting perhaps a reactive lymphocytosis. The patient was started on oral dexamethasone, and his headache, confusion, slurred speech, and gait disturbance improved. The patient was also started on an ABVD chemotherapy regimen for Hodgkin's lymphoma, and he discharged home with close follow-up. He returned close to his baseline mental status. So given his pleocytosis on his lumbar puncture and negative CSF cytology and flow cytometry, we think the patient had cerebellar degeneration syndrome. This is a paraneoplastic syndrome that can be associated with Hodgkin's lymphoma. We thought of a differential of leptomeningeal carcinomatosis, which would be due to direct spread of Hodgkin's lymphoma into the CNS. However, this is a very rare finding in Hodgkin's lymphoma, about 0.1%, and it's unlikely without positive flow cytometry and cytology on lumbar puncture. So in this case, we're going to learn about describing paraneoplastic syndromes, understanding the diagnosis of a paraneoplastic neurologic syndrome, especially cerebellar degeneration syndrome, and we're going to understand the treatment and prognostic implications of these syndromes. So a paraneoplastic syndrome are disorders that can cause morbidity and mortality that coincide with the malignancy. Most importantly, they are not due to a direct tumor involvement or metastatic spread. They can involve the CNS, but the paraneoplastic syndromes that involve the CNS are pretty rare, presenting only about 1% of all malignancies. Cerebellar degeneration syndrome is the most common paraneoplastic syndrome affecting the CNS in Hodgkin's lymphoma. Classic symptoms include confusion, headache, gait ataxia, and dysmetria. The diagnosis can be made without further testing if the patient has classic symptoms for the cerebellar degeneration syndrome and they have a confirmed diagnosis of Hodgkin's. However, if the clinical course is unclear, you can order anti-TR and anti-Purkinje antibodies as a confirmatory test. Treating the underlying Hodgkin's lymphoma usually resolves these symptoms. However, there may be potentially irreversible neurologic damage despite treating the tumor. So in conclusion, paraneoplastic syndromes are important, rare, and overlooked cause of altered mental status. Morbidity is not caused by direct tumor involvement or metastasis. Treating the underlying condition often resolves the symptoms. However, there can be potentially lasting irreversible neurologic damage despite treatment. Thank you very much.